One of the biggest myths about REDS is that routine blood work will identify it, and it actually doesn't. And that gap between what standard testing finds and what's actually happening is exactly why so many athletes spend months or even years being told everything is fine when their performance continually declines. So we've spent the last two videos establishing what REDS is and why it produces such a broad and systemic set of consequences. So today's video is about the question that follows naturally from all of that. How do you actually know if you have it? And the honest answer here is that identifying REDS requires a different kind of investigation than most athletes have ever had before. Not because the condition is rare or exotic, it's neither, but because the markers that reveal it aren't part of standard medical workups, and the ones that are included are frequently interpreted through a disease screening lens rather than a performance lens. Now, those are two very different bars, and most athletes fall into the gap between them. I'm Dr. Jason Barker. I'm a naturopathic doctor, two-time Ironman finisher, lifelong endurance athlete, and 20 plus years working with endurance athletes. So let's go through how I actually approach identifying REDS in clinical practice. Now, it starts with history and listening very carefully. So before any lab is ordered, the most important diagnostic tool is a thorough history. And I don't mean a standard intake form. I mean a detailed conversation about training load, dietary patterns, body composition goals, performance trajectory, and symptom timeline. The pattern I'm listening for is very specific. An athlete who is training consistently, eating what they consider a healthy and disciplined diet, and experiencing a cluster of symptoms: fatigue that doesn't resolve, declining performance, slow recovery, mood changes, recurring minor injuries that don't have an obvious explanation and haven't responded to the usual adjustments. What I'm also listening for is the cultural context. Athletes who have adopted low carbohydrate approaches for body composition or metabolic health. Athletes who are using intermittent fasting or extended eating windows. Athletes who are consciously trying to stay lean as they age and have gradually reduced caloric intake without adjusting for their training demands. None of these are inherently problematic, but in the context of a high training load, any of them can create the chronic energy gap that drives REDS without the athlete having any intention of underfueling. The history also tells me whether the symptom timeline makes sense for REDS. This condition doesn't develop overnight. It develops over months, sometimes even years, of chronic energy insufficiency. Now, an athlete whose symptoms have been slowly worsening over an extended period of time, particularly in the context of sustained training and disciplined eating, fits the REDS pattern in a way that acute illness or simple overtraining typically doesn't. So the first step is estimating energy availability. So before we get into labs, there's a useful clinical tool worth discussing, and that is estimating energy availability directly. Now, energy availability is calculated as energy intake minus exercise energy expenditure divided by lean body mass. The threshold that the research consistently identifies as problematic is below 30 kilocalories per kilogram of lean body mass per day. Below 45 is considered suboptimal here. And the challenging reality is that many athletes with REDS are operating in the 20 to 30 range, sometimes lower, without even realizing it. In practice, getting an accurate energy availability calculation requires dietary recall data and training load information. It's not perfectly precise, but even a rough estimate can be illuminating. An athlete training 10 to 12 hours a week with a high aerobic intensity who is consuming 1,800 or 2,000 calories daily is almost certainly operating at a significant energy deficit relative to lean body mass, regardless of how healthy that diet is in terms of food quality. I use this estimate alongside the history and lab work, not as a standalone diagnostic, but it's often the number that makes the picture click for an athlete who has never connected their caloric intake to their training energy cost. Okay, now let's talk about what to actually test and what the results actually mean. First up is ferritin. This is not just an iron marker. Ferritin is the stored iron marker, and as we've covered in earlier videos in this series, it has to be ordered separately from an iron panel. It doesn't just come with it. First, iron deficiency is genuinely common in endurance athletes with REDS, particularly female athletes, because dietary iron intake is often insufficient alongside the other dietary gaps that characterize this condition. Low ferritin directly impairs oxygen delivery and aerobic capacity, and it compounds the fatigue and performance decline that REDS produces through hormonal mechanisms. Second, ferritin is considered an acute phase reactant. It rises with systemic inflammation. So in athletes with chronic low-grade inflammation from REDS, ferritin can be falsely normal or even falsely elevated, masking actual iron deficiency. This is why I always look at ferritin alongside other inflammatory markers and the full clinical picture not just in isolation. For endurance athletes, I'm looking for ferritin above 50 and ideally closer to 75 or a little higher. The standard lab reference range, anything above 12 or 15, is not the right target for this population. All right, testosterone and sex hormone binding globulin, or SHBG. As we covered in the last video, total testosterone alone is an insufficient measurement as well. You need total testosterone, free testosterone, and sex hormone binding globulin together because SHBG determines what fraction of total testosterone is actually bioavailable to the tissues. In athletes with REDS, the pattern I see most frequently is total testosterone that looks marginal or low normal, not dramatically deficient, just not where it should be for someone training at this level, alongside SHBG that is elevated, which further suppresses the free fraction. The total number looks passable. The free testosterone available to drive adaptation is significantly lower. This applies to both men and women. In women, testosterone is naturally lower, so even small absolute drops in the free fraction are functionally significant. And in women with REDS who are also perimenopausal, the training-driven suppression compounds the natural hormonal transition in ways that can be quite significant and are frequently attributed just to getting older. Next one is estradiol. So in women, estradiol, the primary active estrogen, gives you direct insight into ovarian function and the downstream hormonal support for muscle repair, bone maintenance, and neurotransmitter regulation. Low estradiol in a premenopausal woman who is experiencing menstrual disruption is a straightforward finding. But as I mentioned earlier, some women with REDS maintain apparently regular cycles even with significantly suppressed estradiol, which is why testing matters rather than using menstrual status alone as a proxy. In perimenopausal women, interpreting estradiol requires understanding the natural trajectory of the transition. You're looking for levels that are lower than expected for where she is in that transition, rather than just a number below a reference range. In men, estradiol matters because it reflects the conversion of testosterone to estrogen through aromatase. And when testosterone is suppressed in REDS, estradiol declines with it, removing its support for bone health and cardiovascular function. Okay, next is cortisol rhythm. So a single cortisol blood draw is not useful here for all the reasons we've already covered in this series. What is useful is a multi-point salivary cortisol test that maps the full diurnal pattern across the day. In athletes with REDS, I typically see one of two major cortisol patterns. The first is chronically elevated cortisol across the full curve through the day. The system has been in a sustained stress response state, which is consistent with earlier and less severe REDS. The second is a flattened or blunted pattern. Cortisol that can no longer generate appropriate morning peaks, which reflect more prolonged adrenal or HPA axis compromise. The second pattern is more concerning and typically associated with a longer recovery timeline. Okay, the next hormone is dehydroepiandrosterone sulfated, or DHEAS. So as we covered in the mechanism video, DHEA declines in parallel with the cortisol suppression of adrenal anabolic function. So DHEAS, the sulfated storage form, is the most reliably measured version in the blood. Now, low DHEAS in the context of the other findings on this panel confirms that adrenal compromise is significant, that the body has been prioritizing stress response over anabolic output for a sustained period of time. And because DHEA naturally declines with age, this finding is particularly common and particularly significant in masters athletes. So the cortisol to DHEA ratio is clinically meaningful here. High cortisol relative to low DHEA reflects a system that's heavily weighted towards catabolism and away from the anabolic hormonal environment that recovery and adaptation depend on. Next is thyroid. We need to get a full panel here. TSH alone is not sufficient for the reasons we covered in detail in the last video. The T4 to T3 conversion is suppressed in REDS as a deliberate energy conservation strategy, and that suppression is invisible to TSH, which only reflects pituitary signaling about T4 production. Now, the full panel I use is a TSH, a free T4, and free T3, also thyroid antibodies. The pattern I'm looking for in REDS is normal or low normal TSH, normal free T4, and a reduced free T3. That combination, normal at the production level, impaired at the conversion step, is the thyroid fingerprint of chronic energy deficiency in athletes. Standard testing misses it because free T3 is almost never included in a routine panel. Okay, let's talk vitamin D. Vitamin D is relevant to REDS for several reasons as well. It supports bone metabolism alongside estrogen and testosterone. It modulates immune function, which is already compromised in REDS. and deficiency is independently associated with impaired muscle function, increased injury risk, and reduced performance. For athletes with RED-S who are already dealing with bone remodeling disruption and immune compromise, vitamin D insufficiency compounds both of those consequences. I'm looking for levels between 50 and 80 nanograms per milliliter, not the standard sufficiency threshold of 20, which is calibrated for disease prevention rather than athletic performance. Next is a complete blood count. A CBC gives several pieces of useful information in the context of RED-S. So there's some red blood cell indices, like mean corpuscular volume in particular, that can reflect early changes in B12 or folate status that can accompany chronic dietary restrictions. White blood cell differentials can show patterns consistent with chronic stress or immune suppression. And hemoglobin, while less sensitive than ferritin for early iron deficiency, provides some context for the ferritin finding as well. Okay, bone density. So DEXA scanning for bone mineral density isn't part of the initial workup in every athlete, but it becomes really important when there's a history of stress fractures, when RED-S is suspected to be long-standing, or when the athlete is postmenopausal or significantly estrogen deficient. Bone density loss in RED-S is silent until a fracture occurs, and by the time a fracture happens, meaningful bone loss has often already occurred. For masters athletes where age-related bone loss is already occurring alongside RED-S-driven hormonal suppression of bone remodeling, I have a lower threshold for ordering a DEXA scan as part of that evaluation. Okay, what are some performance clues that complete the picture here? So lab work and history don't operate in isolation. There are performance markers that support the RED-S picture when they're present. These include things like heart rate variability that's trending downward over a sustained period, resting heart rate that's gradually elevating, power or pace at a given perceived effort that's declined without explanation, heart rate that's higher than usual for the same training output, which reflects the cardiovascular stress of operating in an energy deficient state, recovery between sessions that's measurably slower than historical baseline. Now, none of these are diagnostic in isolation, but when they occur alongside the symptom pattern and lab findings we've discussed, they add clinical confidence that the picture is consistent with RED-S rather than simple overtraining or age-related decline. Okay, let's put the whole picture together here. So the diagnosis of RED-S isn't a single lab value or a single finding. It's a pattern, it's a constellation of your history, energy availability estimate, hormonal markers, nutrient status, and performance data that collectively points to chronic energy insufficiency as the underlying driver. The patterns that are most diagnostically compelling include suppressed testosterone and free testosterone alongside an elevated sex hormone binding globulin, low DHEA sulfate alongside dysregulated cortisol pattern, reduced free T3 with normal TSH and T4, low or functionally insufficient ferritin, vitamin D below the performance threshold, and a history that includes sustained high training load alongside disciplined eating that may not be calibrated to that particular training load. When those findings occur together, and they frequently do because they all share the same upstream cause, the picture is RED-S until proven otherwise. And when an athlete has been told their standard labs are normal while experiencing all of this, which is the most common presentation that I see, it's not that nothing is wrong here. It's that the right things weren't tested or weren't interpreted through the correct lens. Now that you know how to identify RED-S, the next question is, what do you actually do about all of this? And here's where a lot of athletes make a critical mistake. They just try to train through it and hopefully that goes away someday. Now in the next video, we're going to cover what actually gets you back to full performance and why the recovery approach matters as much as the diagnosis does. Please hit the like and subscribe. I post science-backed content for athletes at every stage and level. And for individualized evaluation, including the complete testing panel we just covered, visit naturalathleteclinic.com. I'm Dr. Jason Barker. Thanks for watching, and I'll see you in the next one.